Well, thank you. I don't know how I can live up to Terry just doing a talk spontaneously there. But anyway, so yes, I'm going to be talking about teleaudiology and is it the future of audiology? So what I want to do then is just kind of give an overview of where we are with teleaudiology. And throughout, I'm going to sort of integrate questions, implications, and research needs. A lot of what I'm presenting today comes from a conference that we held at the NCRER in Portland last summer, so I should thank the presenters, most of whom are not here, for helping with this presentation. So to make sure we're all on the same page, I want to begin briefly with a definition of teleaudiology. So what is it? It's the delivery of audiology services and information via telecommunications technologies. And I want to provide that definition because it's an important point to make that teleaudiology is not a separate subspecialty of audiology. It is audiology that uses technology to facilitate what we're trying to accomplish. And I think that puts it into a different framework when one is thinking about it. There are 4 typical methodologies used, and I'm just going to briefly describe each one so that you can see why they apply to audiological interventions. So one approach or one methodology is what's known as store and forward, where data are collected at a remote site from a patient, and then they are transmitted at a later date for a healthcare professional to review. Then there's synchronous or real-time teleaudiology, where through video conferencing you're simultaneously communicating. There's remote monitoring, where a patient will be wearing some kind of device that is gathering data that is being sent remotely to a healthcare provider for analysis. And then there's mobile health, which is kind of a patient-driven, independent of the practitioner use. And as I said, these are all applicable for various audiological practices. What I'm going to focus on today, though, is that mobile health thing. And the reason I'm going to focus on that is because that, I think, opens up the biggest unknown for the field. When it's something that audiologists are running for themselves, I think we sort of know where we're going, we have control of it. Whereas the mobile health, as you'll see, there's a lot of stuff out there that we really don't know what it's going to do. Before I do that, though, I'm just going to very briefly describe a couple of successful programs that are going right now in the US. First one then is the Alaska Federal Healthcare Access Network that was established back in 1998, and it provides service across Alaska to many, many patients. In terms of audiology, it's used for a variety of different things. Just to show you some of the positive outcomes, one aspect of Alaska is it's huge. It's very expensive to travel from place to place. Most of the physicians are located in Anchorage, where most of the patients are not. So this is the travel savings in miles that have been noted since teleaudiology came into practice. And apparently, they estimate that they have saved many, many millions of miles over time. There is, why am I having trouble with this? An associated travel dollar savings, and here they are. The graph looks very similar, and they've saved many millions of dollars as well in travel. Maybe more importantly, wait time used to be greater than 5 months in 47% of the cases. Now they're down in the single digits for appointments. And this isn't audiology specifically. This is just general telemedicine in Alaska. Provider satisfaction is very high, with more than 60% or up to 90% of people agreeing with these very positive statements. Likewise, patients, this is just from a few individuals, but patients as well are very satisfied with it. Moving on to VA. VA, again, has a very well-established active telehealth program, born, no doubt, out of necessity, in as much as many, many patients live in rural and highly rural areas with a long travel time to a VA hospital. In terms of audiology, there are over 1.6 million veterans who need audiological services. They have a number of ongoing research projects right now. I'm going to focus on one, which is a pilot program looking at remote hearing aid programming, in which there is a technician and a patient at a rural location, and there is an audiologist at a bigger hospital who is doing remote programming of the hearing aid. So the question is, are the outcomes equivalent for face-to-face and remote programming? And so in this next slide, what I show is outcome using the IOIHA, which is an established hearing aid outcome measure. So on all of these dimensions, what you need to note is that the green bars, which are the teleaudiology encounters, are as high or even higher than the data for all veterans. And being the VA, of course, there is an awful lot of data there. Point being that it seems that the remote programming is as successful as face-to-face. Okay, so now, though, I want to move on to that mobile health, that patient-driven stuff. What is it doing for us at the moment in terms of audiology? Well, teleaudiology, or at least technology, has definitely made it easier to access a hearing test. There are lots of online hearing tests out there. There are apps for testing your hearing. There's telephone screenings to test your hearing. These, of course, all raise issues that we need to think about. So first one is, are the data accurate and valid? We don't really know. Clearly, some of these measures are well designed and they have been proven to be valid. Not all of them. Of course, false negatives would be a problem. If we're telling patients they have normal hearing and they don't, we're not going to be encouraging them to do anything about it. Another thing that I think is an issue is, do people actually understand the results that these apps and online tests are providing them with? There is definitely an issue with communication and health communication and whether or not patients actually understand what they're being told. Now, it's perhaps no different than many patient-clinician interactions because it's pretty well known physicians and clinicians talk at a higher level than their patients. But in a face-to-face interaction, the patient can ask a question, whereas with these remote kind of testing things, they can't ask a follow-up question. So it's all the more important that we make sure that the information given is understandable. And then, of course, very importantly, the bottom line, in many ways, do these self-conducted tests at home motivate behavior change? Does somebody go and get a hearing test if they're told online they failed the screening? Well, there's a little bit of data to look at that. This is a study from Australia where they looked at actions taken by individuals who phoned a telephone hearing screening test, and if they failed the test, it was recommended they got a hearing test. Well, who did? So of 193 individuals who failed that test, only less than 40% actually went and followed the advice that they had been given. And of those, only half of them who were recommended a hearing aid got a hearing aid. On the other hand, this is really not that different to face-to-face screening. This is another study. This was a face-to-face screening study that was conducted in the VA, as it happens. And in that study, of 650 individuals who screened positive for hearing loss, and it was recommended they go get a hearing test, less than a third of those individuals actually did, and again, less than half followed up and got hearing aids. So the issue isn't teleaudiology per se. It doesn't seem to me. So what can we do about it? Well, I think what we need to really understand is more about the attitudes and beliefs underlying hearing health behaviors. What motivates somebody to engage in those behaviors? And that's, I think, where we really, really need to go. Public health messages are a good start. And as I sort of mentioned this morning, I think they need to be targeted, different messages for different age groups. So we're sending a different message about what people should be doing. Okay, technology has also made it easier to access hearing assistive technology. Firstly, in the end of the last session, people alluded to the alternative distribution systems. So in a traditional kind of setting that we're all used to, a patient either obtains their hearing aid through an audiology, private practice, or through a big store. And they both definitely involve hearing professionals. Now, with online retail, there are a lot of conditions in which I cannot make this thing work. Okay, so there we've got our various online ways of retailing hearing aids. Two of these would involve some level of hearing professional involvement, but one of these does not. And so I think that's possibly a concern. It's certainly something that we need to be thinking about. So I think what we have to say is that these new models are controversial, but they're inevitable. And especially with the increased availability of personal sound amplification systems. So what role would audiologists play if people are bypassing that? And that's something, again, we have to think about what the implications are. And clearly we don't know yet. So we need to be conducting that research to find out how these alternative models are going to impact outcomes. Other ways you can access technology using high-tech things. You can turn your smartphone into a hearing aid. Lots of apps out there to do that. What are the issues raised? Well, I mean, basically, we don't know what these apps are doing. We don't know whether they have any value. Maybe they are an entry form of hearing aid. I don't know. I'm sure there are lots of strong opinions about it. But again, we need to do that research to find out what the implications are. Technology and tinnitus management. There are now a lot of apps for tinnitus management. At the moment where I work, there is an ongoing study at the VA looking at telephone tinnitus management. So it's not terribly high tech, but it would be considered teleaudiology. How does that telephone counseling help? We don't know yet. There is a lot of home-based, online, computerized auditory training that Terry Chisholm alluded to this morning. Is it effective? Well, as she had said, that the findings are mixed. We did a large randomized controlled study of LACE, and we found really no positive benefits of LACE on a group level when it was compared with a sham auditory training condition and the standard of care education. But within each group, there were people who benefited. So by doing a randomized controlled trial, we have lost the ability to look at some of those individual differences that perhaps predict outcomes. So what we need to do is, with these things, is we do need to better identify who will and will not benefit from things like auditory training. On the other hand, there are really few downsides to conducting auditory training. So is it a problem if people do it and it only benefits a few percent? Probably is not a big problem. There are also a lot now of online hearing-related counseling programs and support groups, chat rooms, et cetera, et cetera. Once again, there is really very little work done to look at the effectiveness. There's one study done by Toren et al. They did a remote RCT comparing online education by a professional with an online discussion forum with peers. And they found that both groups actually did decrease in their hearing handicap, and that there were different psychosocial benefits among the two groups. So it is a positive sign that these online kind of counseling or chat groups are helpful at some level, but once again, we really don't know. Also seems important to know, well, what do patients and clinicians think about teleaudiology? And it's another, it could potentially be a barrier, it could be a facilitator, depending on what opinions are. So Gurjit Singh and Kathy Pecora-Fuller and their colleagues did a couple of surveys of patients and clinicians. This first one here then was looking at clinician willingness to use teleaudiology. They surveyed 202 clinicians and asked them what procedures would they be willing to use teleaudiology with. And so what we have here is the proportion of respondents, and these are the different procedures. And here that's the first fit of a person who's already worn hearing aids, incidentally, and that's the first fit of a brand new patient. So what did they find? Well, we have here, anything in green is a pretty positive willingness. In white is a somewhat neutral, and in red is a they're not willing at all. And so what we see is for these kind of interactive counseling and answering questions, they are more than willing to, or pretty much uniformly willing to use teleaudiology. When it comes to these three middle procedures, around 50% of people are moderately or more willing to use teleaudiology. But when it comes to new patients, they're really not willing to use teleaudiology at all. Similar data from 224 patients. There is a pretty broad range of responses. On average, I mean, more than 50% of people are moderately or more willing to try teleaudiology. And I think what's really important, though, is this is data collected by Phonak in Germany. Can you change people's attitudes and opinions? I mean, people may come in with it negatively, but what do they think after they've engaged in it? So they looked at attitudes pre to post remote hearing aid fine-tuning. And what they found amongst just a small number of subjects, 16 patients, who after they had had remote hearing aid programming, 2/3 of them had a more positive opinion about doing the adjustments remotely. Likewise, the clinicians, it was the same proportion, became found it more favorable after they'd used it. So I'd say we can change attitudes, and that's probably good news for teleaudiology. It does say to me that we do need to approach the education of clinicians about teleaudiology very carefully, because they could be a barrier or a facilitator, and so we have to make sure that we make that work well. There are a whole host of other things that I can't possibly talk about today. I haven't got time. I've underlined some of them. They are the things that I feel like researchers and clinicians have a real possibility to control and access. These other things, I think, are administrative things that they don't. So, to summarize, teleaudiology provides easier access to hearing healthcare at many levels. I think that's pretty established. There are greater diversity of options for audiological rehabilitation, and is generally acceptable to patients and clinicians. It could or should, therefore, open up hearing healthcare to a broader demographic of individuals. I'd say the major research needs, we really do need to validate the data we're collecting. I mean we need to collect data and validate what's coming out of it. We need to optimize the usability and effectiveness. We need to understand outcomes. And there definitely remains a need to change hearing health behaviors so that people access the many options that are available. We've heard in a number of presentations that people don't actually go access what they should. So, my very final slide to conclude. The question isn't, will teleaudiology happen? It will, and it already is. But how will it happen? And what can we do to ensure it yields positive outcomes for both the patient and the professional? Thank you.
So, thank you, Gabrielle. Now we come to the last speech in this session, and that is by Thomas Powers, who is a family doctor in Arizona, who's going to tell us about his experiences on hearing loss and primary care.